Right, so here we are. We're going to talk about something which is a bit touchy, which is surgeons taking their own medicine. And the way this started was at ACOS in the summer. I was presenting on Presbyon in the middle of, I was like this little goldfish in the middle of this shark tank of people putting in diffractive optics, and I presented on Presbyon. And Fernand here, my good friend from Belgium, was very annoyed because he had to buy these glasses from the supermarket because he forgot his reading glasses in Belgium. And after my talk, I sat down and he said, you know what, I'd like to do Presbyon. Could you think I can have it? I said, well, I don't know, but we can check. I go, what's your prescription? He goes, I'm basically Plano. I said, well, chances are yes. I said, well, let's do this. Let's do it, not now in June, but let's do it in November, 3 days before the next course, so that we check you, we convent, we do the double check, we do your surgery on Wednesday, and on Thursday, you can present your case and explain how you went from being someone who does clear lens exchange on everybody to being someone who did something different on his own eyes. And he said, okay, well, let's do that. And he presented, and in the audience was this guy, Rob Morris, who's the medical director of Optegra here in the UK, whose website said, laser can't fix presbyopia, we have Clariview. Clariview was basically clear lens exchange with a multifocal, but they put a different name on it. And he came up to me at the end of the course and said, you've really put me in an awkward position because next Wednesday I have 20 clear lens exchange eyes to do in 10 patients, and I feel very uncomfortable about it. Secondly, I'm 62 and I'm a -5, and I just wondered if you wouldn't mind doing my Presbyon for me. And I said, wow, yes, but on one condition. The next course in June, if you come 3 days before, and so on. And so this has been a bit of a chain reaction, okay? And actually, interestingly, we have somebody from Australia here, an optometrist, who also had Presbyon. There he is, up there, not wearing spectacles for the talk. And here we are. So we now have the same two. This time they come in twos, and we can go up to as many as you like before each course. Bola, she wrote to me about a month ago, she says, I'm coming to the course, but you know what, I was thinking about doing this. And Lee, who's Australian, going back to Australia soon, he's finishing his fellowship in Cardiff, Bristol, very close. And he said, you know, I'm pretty convinced about this thing. And so we said, sure, let's do it. And here we are.
My name is Abimbola Ashaye. I'm an ophthalmologist, refractive surgery in Lagos, Nigeria. I've been in practice for 15 years now. I started wearing glasses because of presbyopia last couple of years. I'm more dependent on it right now than before. When I started attending the courses here, I kind of got interested in Presbyon more and more. After practicing it myself and seeing the outcome, I just decided, why not go for it? And I did it for a colleague of mine, and she was super happy. I've attended this course several times. And the way Professor Weinstein, talks about it, with the confidence, I just want the best. And I decided to have the best.
Does that feel all right for you?
Yes.
Yeah.
Right. Everything's going to be very easy. Yeah? I'm going to walk you through it one step at a time, super easy. You just keep listening to me. Perfect. And we'll take the pressure off. Fantastic. Excellent. Super. How was that? Pretty interesting, huh?
Done?
Well, that's the femto flap, yeah. Alrighty. -8.
I'm looking forward to freedom with glasses, reading, and then sometimes when you're with patients and they see you grabbing your glasses to look at the results or, discuss things with them, why are you wearing glasses if you're trying to make me not, So the confidence you talk, after I had the procedure myself, they get more convinced and sure of what they're doing.
Let's check you with the microscope. So watch your step here.
Okay.
This time it's you're on this side.
Side is this side.
That's funny. I did exactly the same
Yeah,
thing
the same
in here.
thing.
Exactly the same thing.
Yeah, it was a wonderful experience because, you never got to experience it myself, but now I can say it's easy. It was just seamless. It was very comfortable.
So my name's Lee Holland. I currently work at the Bristol Eye Hospital and I'm an ophthalmologist with special interest.
Could you stop it? Did you put the video inside PowerPoint?
Previous life as well.
Do you think you could play it straight outside of PowerPoint with VLC?
I've worn glasses for about...
It just might not be jerky. Looks like a 1918 silent movie. It's nice. Nicely edited.
My name is Abi. I'm looking forward to freedom with glasses, reading, and then sometimes when you're with patients and they see you grabbing your glasses to look at their results or, discuss things with them, why are you wearing glasses if you're trying to make me not, So the confidence you talk, after I had the procedure myself, they get more convinced and sure of what they're doing.
Let's check you with the microscope. So watch your step here.
Okay.
This time it's you're on this side.
Side is this side.
That's funny. I did exactly the same
Yeah,
thing
the same
in here.
thing.
Exactly the same thing.
Yeah, it was a wonderful experience because, you never got to experience it myself, but now I can say it's easy. It was just seamless. It was very comfortable.
So my name's Lee Holland. I currently work at the Bristol Eye Hospital and I'm an ophthalmologist with special interest in corneal, refractive and glaucoma surgery. I was an optometrist in a previous life as well, and so I think I've always been interested in getting the best possible refractive outcomes for patients. I've worn glasses for about 30 years and a little bit less for contact lenses. It's really just as my children have become more active, it's made more sense for me to seek refractive surgery. Microanisometropy is an excellent solution for presbyopia. Dan's Presbeyond, with the manipulation of spherical aberration, just adds to the effectiveness of that. I'm excited. I want to make sure I'm a good patient and I do the right thing, but I'm excited mostly.
Perfect. And I'm going to tilt you a little bit over to this side, so just resting like that. That's great. And a little wet sponge here. Keep looking straight. Everything goes very blurry, very blurry. You're just looking straight up into the center of the flashing cloud. The light's going to go red. You're looking straight. And your job is just to continuously look into the center of the green flashing where it's brightest. Fantastic. Okay, Lee. That's perfect in both eyes. Should in a few hours.
As I said to Dan, I'd almost like to experience it again because I was trying to hang on to every moment, knowing the procedure, of course. You're trying to analyse the procedure as a patient, and in summary, it's very simple, it's very quick, and it's very comfortable as well. So very interesting to be on the patient side of the table.
Nicely edited.
Is that Tim's hand? Right.
Microphones? Oh, I have a microphone. You have microphones?
Yep.
Oh, you're all mic'd up. Oh. Efficient. So Tim's going to present these slides, which are the
Well, you can just talk through and
clinical features. Well, I haven't seen them.
yeah, I know. So you can.
I mean, I treated her, but okay, so here you can see Bola. She was 2025 uncorrected, N8, N6, best corrected 2016, distance corrected N10, so presbyopic, with a very, very mild myopia in the right eye, and the left eye, a slight hyperopia. Yeah. And you can see her epithelial maps. Now, interestingly, her corneas were on the thin side. I don't know if you have the pachymetry on those slides, but her corneas were about 450 or 460 microns, right? So that's thin. So we actually looked this up, and Ruchi went and checked, and we found these papers coming out of the States where they look at African Americans versus white Americans, so they're same food, same junk food, and their corneas are 20 to 30 microns thinner on average. So it's interesting. It's very important, I suppose, for glaucoma because I guess that means that they're underdiagnosing glaucoma, right? I guess, yeah. Anyhow, this is her post-op. So this is post-op day 1, plano minus 1.875. Target is going to be 150. So as you can see, that was a hyperopic ablation in the left eye. That's going to come back perfectly. And she was seeing 2016 minus 2 and reading N4 and N10 at intermediate. Binocularly, though, N4, N8 at intermediate. Was that right? No, I don't have that there. Okay. And then you look at these anamorphic scans from the MS-39, which stretch the z-axis by a factor of about 20. And as you can see beautifully, you can see that this parallel flap, parallel to the surface, 90 micron flap in both eyes. The Bowman's is very, very smooth. There's 0 microfolds. And she had, a little bit of staining around the edge of the flap, but you didn't feel it, actually. You said you didn't feel anything. And the eyes were white, and there was no subconjunctival hemorrhages, which you see with a lot of other femtos. And this is her post-op tomography. You see the epithelial profile on the right eye has the epithelium is thickened a bit, and the left eye, the hyperopic ablation, and the difference map at the bottom. Yeah, so the difference map at the bottom shows the myopic correction in the right and the hyperopic correction in the left, and that's it. Yeah. Any more?
So yeah.
Is that it? Yeah.
That's it, yeah.
So we're just going to talk about one at a time?
Yeah.
Okay. Because what's really important here is not so much the clinical results at all, the numbers. We know that we can correct -8 to +6. The really important thing is how and why and what was your mental process? Because you did take the course several times. It wasn't like you jumped on this in 2 seconds.
No.
What's your story?
Okay, so I've been here several times and listened to the Press Beyond lectures like every year. And I kind of when I started wearing glasses, when it became mandatory for me to pick up my glasses anytime I want to read scans and things, I kind of thought, why would I be offering patients this procedure if I can't tolerate it myself? So last year, after attending the course, I just decided to take my own scans. I was telling Dan that I'd never dilated my pupils before. I always just do because I don't like things going into my eye, putting things. So, funny, right? So I decided to take my scans. I saw my corneas were thin. I said, oh, this might be a problem. But I said, anyway, I'm close to metropia anyway, so I may not need much to be taken off. And I kind of decided last year that I would want to do this for myself, just to get rid of the glasses and, talk with confidence. I've done this before myself and share my experience with patients. And so that was when I decided that if it's possible, I'd like to do it.
Yeah, and so, okay, your corneas are a bit thin, and so therefore, we're concerned about, things. So what did I do to, make sure that everything is okay? And so, the depth of testing goes down even deeper a little bit when you see anything that is not quite in the middle range. Every patient that comes through the door has an epithelial map because of the MS-39. But apart from that, what we will do is go on to the Corvis, because if you had a high TBI, a high total biomechanical index, then it sort of nudges the needle a little bit over to susceptibility to ectasia, and that was actually not high. And obviously the epithelial pattern was completely normal. And although you had displaced inferior, can we go to the pre-op tomographies? You probably didn't put up the keratoconus screening ones, no?
No, we didn't.
Ah, all right. So if you look at her back surface, bottom 6 to the right, she's got a little bit of, temporal elevation in that right eye. But if you look at the epithelial map, which is over, Tim's pointing at it, there isn't a donut of epithelium around that zone. So there isn't focal thinning of the epithelium where you would expect it to be if it was an ectatic process. And so when you find epithelium that's thicker over the posterior displaced apex of the best fit sphere, it kind of excludes keratoconus. I mean, there are exceptions, but basically that's how we exclude keratoconus. And we published this series of 1,500 eyes where 10% of them were equivocal, they all had epithelial mapping, and of those eyes, 84% had LASIK with a Hansetome because they were deemed to be not keratoconus, even though the topography looked weird enough for us to screen them into epithelial mapping. And the left eye, same thing, temporal slight elevation. Many, you know that the Bellin-Ambrosio has a lot of false positives on the Bellin-Ambrosio plot of those 3 plots. It's actually the Bellin plots. The Ambrosio is the thickness progression. And the D can be yellow, sometimes even red. But if the epithelium is normal over that back surface elevation, we do LASIK on them. No, we don't even bat an eyelid. We completely ignore that factor because we think it's a false positive. And we've been doing this for years. I don't want to touch any wood because I don't think I have to. We're looking at anatomy. And if the epithelium changes by 1 or 2 microns, we can detect that. So epithelium is really the most sensitive way of picking up subclinical keratoconus. And so that gave me the confidence to say, they're just thin corneas. Then Rucci did the literature search, and we're like, okay, fine. So your cornea is not 460, it's like a 480. And so 480s wouldn't make my pulse change at all, because it's within 2 standard deviations of the mean. So that was the justification. Plus, you easily passed the plus 150 test with dominance was straight down the line. Plus 150 was perfect. You had no cross blur. So you're just a straightforward candidate for the surgery. And if you were in the surgery, you would have heard that I warned her that I will be speaking the exact script that is in the textbook, warning her that not to expect anything different. But I think we talked about afterwards how I probably did slightly hypnotize you.
Yeah. Yeah, because even during the surgery, I wasn't following the procedure. I wasn't, I was completely, I wasn't going through the process like, I know the process, but I wasn't going through it in my head. I was just, completely in his hands. So I got hypnotized a bit.
Yeah. Mind control. But that's I don't know, Lee. What's
Well, like I said in the video, I did try to go through everything step by step, but it's difficult because I knew certain things were happening, but only because there were visual cues. Like the green light went perfectly clear when suction was applied, but you would not know. There's no sensation of pressure, on the eye. So I was trying to sort of track along and just see how the sensation matched up to what was going on. But yeah. I wouldn't have known. It would have been, if I'd sat there and just taken it, I wouldn't have known what was happening at any given time. It's.
Do you think you stayed fully, like you kept yourself fully conscious, or did you sink a little bit into a daze?
I don't know. That's hard to answer. I tried to stay conscious, but maybe I slip into a daze even when I'm doing that. I don't know. But I did try to stay conscious of each step. Yeah.
Right.
Yeah.
See, hypnosis only works if you want to be hypnotized. I said that, right? No one can make you do something you don't want to do. So if you want to be in a hypnotic state, you can be put into it. But if you want to stay awake and be fully conscious and perceiving, then you will. When I had my Presbyond with Glenn, I actually went into a bit of a small trance where he lifted the flap, and I kind of knew he'd done that, but the lights, the flashing lights, and it's all very kaleidoscopic, isn't it? So, especially when he's setting the tracker and you see the Purkinje reflex hit, suddenly there's this like kaleidoscope of light, and then things kind of get a little distorted, and then during the ablation, it's I don't know. It's like looking at 1978 discotheque ball going around at 10 times the speed. So it's just lots of lights everywhere randomly.
But it was over so fast, I didn't even believe it.
No. And almost like I was sad that it was so I wanted more ablation. I was like, hey, could you put in an extra -5? I just want to see those lights. It was very good, very good. How do you? I mean, what do you think of? I mean, how does this? How does your experience now on this side of the equation versus last week before you were on this side? How does that change your perception of some of our colleagues here who are wearing glasses and are over the age of 45?
I think for me, it wasn't that I didn't want to have it done earlier. It just, circumstances just weren't that, think the stars aligned and it was easy for me to have it done, training, fellowships, COVID, all the rest of it.
Sure.
I'd say I should have done it earlier, but I'm happy with the way things worked out because, I got to this point. I've now had a presbyopic correction as well, which I spoke to you about, and I'm glad that I went down that path. So I feel like I've gotten everything I need now just in one treatment, and I might, that might have been my second treatment. Not that that would be a problem anyway, but I felt like it was a good time for me. I would have told you I didn't have a problem with specs, but at the same time I knew that my life would be better without them, and it obviously is. So I wasn't fearful of the consequences or what if something goes wrong. But in my personal circumstances, it was just that if I had have made the opportunity happen earlier, it may have. But this was the time when all the stars aligned for me, and I was able to.
You first took the course last year.
Yeah,
right?
yeah.
So that must have been a fulcrum.
I guess there's ignorance is bliss, and then there's knowledge is good as well. And I sort of, over the course of the past 2 years, I guess I put myself in that basket because, as I spoke to you about, I studied for the Cert LRS, went to the course, and I just became convinced about the safety of the technology. Not that it was a big problem for me beforehand, but certainly the more I felt I knew about it, the less I became worried about having it done myself, for sure.
Yeah, knowledge dispels fear.
Yeah.
Is the dictum, and and as I mentioned this in our clinic, our consent forms is the surgical information package is 38 pages, and the consent form is 10 pages, and that's for a standard -1 anything. That's for a regular -1 22-year-old. So we give excessive detail by most standards, but we have found that for us, that works very well for the style of practice that we have and for the people that we pretend to be in terms of our rigor and our inclusion of information and our lack of salesiness, which is part of our personality as a medical clinic, delivering what is a very commoditized procedure. And we've never found that giving excessive information puts off the right patient. Yeah. It'll put off the wrong patient, but it won't put off the right patient.
Yeah. And I think I mentioned to you, Dan, as well, like I was taking, you know, those little kids, they're sort of 9 and 8 now, and they're really good swimmers. And we're in the UK. They may be the only Australians ever to learn to surf in the UK, but they have. And you know, we're going to the beach, and I wear contact lenses in the water because they can get themselves into trouble now where they'll need a grown-up to bail them out. And if there's a choice between wearing contacts in water and not being able to look after your kids, you know, that's what I do. And fortunately, I haven't had to do it too much because this is the UK, but when I go back home, that's completely different. And that's a risk I'm not prepared to take anymore either. And, you know, every time I put that lens in and went into the water, I knew that, you know, that there was a chance that that scenario might not yield a great outcome, but you did it because, you know, you've got kids and you've got to look after them. So,
Yeah.
yeah.
Yeah. Anything you'd like to add, Bola?
You guys still wearing glasses? I wonder why. After all this, it's something one should. Anyway, it depends. You know, some people like their glasses, so.
Yeah, I hear that phrase, and my answer to that is, okay, no problem. You can have surgery so you're not a visual cripple, and then wear glasses with just clear glass. The same thing. I mean, not being able to see is a disadvantage.
Yes.
When I'm consenting patients who are above -4, -5, and I talk about the risk of losing 2 lines of best spectacle corrected vision being 1 in 1,000, and that is the equivalent of daily disposables worn daily for 3 years, or monthlies worn for 8 months, it's a no-brainer to switch to surgery. I then say to them, but glasses are also a risk. And then they go, how? And I go, because you're blind as a bat. And so if you're in a dangerous situation and your glasses get knocked off, you could break your neck. So you actually don't have a 0 risk option. You only have 3 risk options: contact lenses, glasses, or surgery. You don't have a 0 risk option. You gotta talk to your parents about that. You don't have a 0 risk option. And so anybody who's high myopic, that's it. They have a disability. I mean, it's a socially integrated disability because no one says, where's glasses? Genetic defect, don't marry her. Unless you're in southern India. In southern India, that is exactly what happens. And you have girls who are 18 years old and they're -8 and they're walking around uncorrected so that they don't get seen wearing glasses because they won't find a husband. So there's a cultural problem with glasses in some societies, not ours. Here, you know, the Hollywood stars make glasses into something that is desirable. Okay, well, that's wonderful. Thank you so much. That's lovely.
Thank you, Dan.